A visual signal originates in the retina and travels down the optic nerve toward the brain. Identifying the exact point of failure when that signal is interrupted requires a systematic deconstruction of the visual pathway. Take the case of a patient reporting constant, sudden-onset vision loss. The condition has remained strictly stable for exactly 1 year, providing a fixed clinical profile to investigate. To isolate the cause, we use a diagnostic funnel. This allows us to move through the anatomy of the eye, determining if the pathology is anterior, retinal, or located within the neuro-ophthalmic system. The first stage is a targeted history to define the exact nature of the deficit. For example, we must determine if the patient perceived their vision loss as a physical curtain dropping over their field of view. We also look for associated symptoms that might rule out specific pathologies, including flashes, floaters, pain during eye movement, or pre-existing systemic diseases. These subjective details provide the necessary framework for interpreting the objective tests that follow. Without a specific history, it becomes difficult to differentiate the primary cause of vision loss from unrelated structural variations. The baseline clinical workup begins with standard functional measurements: visual acuity, intraocular pressure, pupil reactivity, and a map of the patient's color vision. A dilated fundus exam then allows for the first direct inspection of the retina and the optic nerve head. To see deeper, we employ optical coherence tomography, or OCT, to capture high-resolution cross-sections of the various retinal layers. These tests establish a physical baseline for the patient, documenting the current state of the eye's physical architecture. While these measurements effectively map the anatomy, they do not confirm how well the visual signal is actually moving through that structure. For this patient, the OCT scan reveals visible defects in the outer plexiform and inner nuclear layers. This suggests specific differential diagnoses: OPL or INL holes, retinal schisis, or localized cycloid degeneration. Viewed in context, these physical anomalies are quite small compared to the overall surface area of the retina. This raises a question of clinical scale. We have to determine if a microscopic physical defect in a specific retinal layer could plausibly result in a sudden, total loss of vision. Visible structural anomalies are not always the primary cause of a functional deficit. Often, a small physical finding is incidental, masking a more significant failure elsewhere in the neural pathway. To look past the physical structure, we turn to electrophysiology. This measures the actual electrical signal processing currently taking place within the eye. A pattern ERG isolates the signal from the central macula, testing the fovea's integrity. By contrast, a full-field ERG tests the functional output of the peripheral retina. This requires sitting in complete darkness for 20 minutes, the clinical standard for isolating rod and cone responses. We can also use a multifocal ERG. Over 15 minutes, this maps the electrical function of localized regions across the retina. While these tests show us where an electrical signal is being generated, they cannot tell us if that signal is actually surviving the journey from the eye to the visual cortex. To track the signal beyond the retina, we use visual evoked potential, or VEP. This monitors the pathway from the optic nerve through to the occipital lobe. In our patient, the right eye's multifocal ERG shows a smaller peak than the control group, while the left eye shows reduced function. However, the left eye's visual field test shows a different pattern, a stark Pac-Man-shaped wedge of missing data. Examining the visual cortex VEP data reveals an identical result. The electrical signal reaching the brain shows the exact same deficit. Finding a deep signal loss in the brain that perfectly matches the topography of a visual field defect is definitive. This neural data takes precedence over the minor, ambiguous structural findings in the retina. We can now synthesize 3 distinct pieces of data: the Pac-Man-shaped visual field loss, washed-out color vision, and the matching VEP deficit in the cortex. This data correlates with the physical appearance of the optic nerve head, which appears pale with indistinct margins. This confirmation allows us to categorize the retinal schisis and holes found on the earlier OCT scan as incidental findings, unrelated to the patient's actual vision loss. The formal diagnosis is an optic neuropathy. This specific combination of functional loss and nerve pallor points to a neurodegenerative condition. It has caused retrograde thinning, effectively degrading the pathway along which visual signals travel. The high-tech workup for an adult contrasts with the needs of a pediatric patient, such as a 5-year-old female presenting with reduced vision in both eyes. In a pediatric context, the diagnostic funnel shifts toward the patient's daily environment. We look for clues in school, their ability to see the blackboard, or symptoms of photophobia. Before ordering advanced electrophysiology, like ERGs or VEPs, a pediatric workup focuses on more fundamental tests, specifically cycloplegic refraction and binocular motility. Establishing a baseline refractive error is a mandatory first step. In children, simple optics must be ruled out before pursuing more complex neurological or retinal diagnoses. Rigorous diagnosis is not just about using the most advanced tools. It is about calibrating the diagnostic funnel to the patient and recognizing when visible structural defects are unrelated to the true pathology.